Here's an outline for this talk. So let's talk a little bit about what tumor-directed ablation is, what the role is for ablation in kidney cancer. And then I'll go into a little bit more specifics about cryoablation, which is freezing tumors, because that's most of what we're doing at Duke and many centers now for kidney cancer. So I'll go into that in a little more detail, how it works, how it's done. I'll actually show you a pretty cool case that we'll walk through together, and then just a summary of what I think caregivers and patients need to know about ablation. So first, what is thermal ablation? Ablation just means removing or destroying tissue. So thermal ablation is a minimally invasive technique that uses extreme cold or heat to destroy a tumor directly. So actually destroy the cancer cells. It's these days typically performed percutaneously, which means through a tiny skin nick, so through the skin with a special needle that directly freezes or heats the tumor, and that's done with imaging guidance, so under CAT scan guidance or ultrasound, often done by an interventional radiologist in the radiology suite. So, what's the role for this in kidney cancer? Well, it's really an alternative to surgery for small renal masses. So that's important. We're talking about small lesions here, 3 to 4 centimeters. And that is, if you don't know, 4 centimeters is about the size of a golf ball. So, golf ball or smaller are really the ideal size tumors for this sort of treatment. And at this point, we've been doing ablation for decades now. So there's a lot of data. Most of the major societies recognize ablation as an alternative to surgery for small renal masses in appropriately selected patients, and is particularly well suited for patients who are not good surgical candidates. So maybe older patients, with other medical problems that make surgery a little more risky. Ablation is something to consider. So why would a patient consider ablation, thermal ablation for kidney cancer? Well, it's an outpatient procedure, so you come in and go home the same day. Patients usually leave the hospital about 2 hours after the procedure. It's done in a single treatment and under moderate sedation, and that's important for some patients. So no need for general anesthesia. It's done with conscious sedation given through an IV. Recovery times are shorter compared with surgery, so most patients are back to normal activities within 1 to 2 days after undergoing an ablation procedure. You walk in and walk out of the hospital, kind of take it easy for a day, and then back to normal activities. Generally, there are fewer complications compared with surgery because we're just doing everything through a very small skin nick. Fewer complications, less blood loss, and importantly, this is preserved kidney function is something that I think an advantage that ablation has. So when we do an ablation, we're really affecting the tumor in a small area around the tumor. So it's the normal kidney is well preserved. You can see an example here on the screen. So there's a tumor circled in red, and then after ablation, you can see the small area that was affected, and all the rest of this uh, bright part here is normal kidney tissue that is not affected. So for some patients, that's really important. If you have one kidney, if you have a kidney transplant, or if you have chronic kidney disease where you really can't afford to lose much function at all, ablation tends not to impact kidney function much. How about limitations? So, everything has advantages and disadvantages. Some of the limitations of ablation are one that it requires imaging surveillance afterwards. So you have to get follow-up CAT scans or MRI. And the time that's how long that's done for varies. I think most urologists are following up to 5 years after ablation. That's to make sure that the cancer is gone and that it stays gone. Imaging surveillance is done after surgery as well, but I think it's a little bit less intensive. It's less ideal for central tumors, so tumors that are kind of near the center of the kidney, near where the urine collects. Ablation is not quite as well suited for those tumors. That's because there's a lot of blood vessels in that area and a little bit harder to get to with the needles. Now we can do it, and particularly if surgery is absolutely not an option, but less ideal. And then finally, and I think importantly, there is a slightly increased risk of needing another treatment. So the recurrence, local recurrence, so the tumor coming back where it initially was, is still very low, but a little bit higher than it is with surgery. So most of the, you look at all of the published series, it's between 5 and 10%. So, 1 in 20 to 1 in 10 patients that have ablation may have to have another treatment in the future. Now, that's still, 90% of patients ablation gets rid of the tumor, forever, but a little bit higher than surgery. So something to consider. But importantly, most of the time when there is a local recurrence, it can be treated with just a repeat ablation. So a single needle at that same spot, again, done in that minimally invasive fashion. Who's a candidate for ablation? We kind of went through this, but really ideal for patients who cannot undergo surgery, older or medically complex patients, patients who have really, it's important to preserve kidney function, single kidney transplant, advanced CKD, chronic kidney disease. And then also, I think patients for whom minimally invasive treatment is a priority. If you say, I really want this done in the least invasive way, and that's a valid request, right? So that's a reason to do it as well. And then tumor characteristics, best for small tumors and tumors that are, and this kind of makes sense, tumors that are accessible, that are in an area that we can safely get to with these special needles. There are a few different types of thermal ablation. So there are heat-based ablations that use radio frequency or microwave to burn the tumor. And then there is cold-based, which is cryoablation. At Duke, and most of what we are doing is cryoablation, but importantly, all forms of ablation have the same goal, which is to destroy the tumor tissue. And there are some cases where one might be preferred over the other. I'll go into a little more detail about cryoablation now because, again, this is mostly what we're offering these days. And cryoablation is freezing the tumor cells with the goal of killing them. It's done by inserting thin cryoprobes or specialized needles through the skin directly into the tumor. And there's an example of kind of what that looks like on the table when the patient has the needles in. And it actually creates an ice ball around the tip of the needle, and that's what the ice ball looks like there. Just testing it in a bowl of saline, but that's what it looks like when when the needle's in the tumor. And this allows a precise control of the treatment zone. So we're able to kind of shape the size and shape of the ice ball to encompass the tumor, small area around it, but not affect anything else. It's pretty interesting how cryoablation works. So this is a zoomed in view of a cryoablation needle. What's happening is we're passing argon gas through the core of the needle, and as it gets into the kind of the outer part of the needle, that gas expands a little bit, and that process absorbs energy. So it makes the area around it cold. That's called in physics, the Joule-Thomson effect is what we're taking advantage of there. So we're pumping argon gas through this needle. It's making the air around the needle cold, and that creates an ice ball. And we want the ice ball to completely engulf the tumor. So you can see that different needles make different size ice balls there in the example in the bowl. And on the bottom right, you see that's a phantom or kind of a fake body that just to show that under CAT scan, you can see the ice ball very well. See exactly where it is and where it isn't. That helps us to be pretty precise with this. Whole procedure is done with CT imaging guidance. So in this example, you can see the tumor circled in blue on the top prior to treatment, and then during treatment with the needle in place, and the blue is outlining the edges of that ice ball, so completely engulfing the tumor. And when we do this, we actually freeze the tumor for about 10 minutes, and we let it thaw, and we freeze it again for 10 minutes and let it thaw again. That freeze-thaw cycle is very destructive for tumor cells. They can't handle it. So it takes about 20 minutes total of freezing and thawing. This is a little technical, but I think you'll find it interesting. So when we're planning these treatments, we use these what are called isotherm charts. You can see based on the size and number of needles and arrangement of needles that are used, we can precisely control the size of the ice ball. So here on the left with one needle, the ice ball will be this size. When you put 4 needles in a square shape like that, the ice ball becomes this big round shape. So depending on the size and location of the tumor, we'll adjust the number of needles that we use. We want the tumor to be right in the middle of the ice ball, just like this, where the ice is the coldest. And the ice ball there that is outlined in blue, the outer part of the ice ball is not as cold. The middle part is extremely cold. So we want the tumor to be right in the center. So here's an example case where the tumor pointed out with the arrows there in the middle image, and then on the right, That's during the actual freezing. So we'll take some pictures while the freezing is taking place. That dark area around the needle is the edges of the ice ball. So, we can be confident completely engulfing the tumor there. So what to expect if for someone who's undergoing cryoablation? Well, it is outpatient, so procedure takes about an hour. It's done under IV sedation. You are awake, but comfortable, and then go home about 2 hours afterward. All done through a small skin nick, through which the needle is inserted. Now, some of you might be noticing that this doctor here is not wearing a mask or a hat, and I noticed that as well. And I just want to make sure everyone knows that he was probably posing for the media. We actually do always wear a mask and always wear a hat. So we'll just throw those on there, just for good measure, right? Here's an example case. So this is a patient with, Dr. George talked about the stages earlier. And what we're really talking about here with cryoablation is stage one, specifically stage 1A, where the tumor is less than 4 centimeters in size. So here's an example of a patient who has a T1A tumor. It's outlined in yellow there. That's the tumor on the right kidney. And so this is during the procedure. So we have patients on their stomach. We do an initial scan, see the tumor, and then we're just kind of planning the course that the needle will take. And that's kind of the trajectory we'll use. Here are a couple of images after two of those needles have been placed based on kind of planning from the chart, the size of the ice ball. And so then, we're getting ready to freeze. But, one thing to notice here is that circled in yellow, that is the colon. So the colon is very nearby the area. So that's something we always think about is we need to make sure there are no other organs or structures that might be affected by the ice. Fortunately, it's fairly straightforward to deal with. So in this case, we see that the colon's a little bit close. In fact, if we zoom in, it's the colon is less than a centimeter from the tumor. So we're not going to want to, freeze like this. What we can do is simply place another small needle between the colon and the kidney, and then we inject some sterile saline. All that bright stuff there is saline with a little bit of X-ray dye in it, and that just pushes the colon away to create some separation. And now the colon is a safe distance, and you can see the ice ball forming there around the tumor. That's the ice ball is blue. The colon is now a safe distance away and protected, and we can confirm that during the procedure. And this is after the procedure is done. So, you can see that the tumor has been frozen. There's still some of this fluid in there. The colon is a safe distance away. That fluid will just get reabsorbed by the body and be gone within a day or so. So after the procedure, after ablations, most patients discharged same day. We see mild soreness at the treatment site, not a lot of pain, not something we're often prescribing pain medications for or anything, and then normal activities in a couple of days. I mentioned imaging follow-up. So most patients will have a CT or an MRI ordered within 3 to 6 months after the ablation procedure, and then annually after that. And what we see after someone has had an ablation, here's an example. 3 months after a tumor was treated, you see the initial ice ball there in blue. As things heal, the area will just kind of get smaller. It has this kind of feathery appearance as the body's healing and replacing that with scar tissue. So that's the normal appearance on follow-up. And we'll just kind of make sure it continues to look that way over time. So key take-home points here, thermal ablation for kidney cancer, high success rates for small tumors. And, cancer-related outcomes are in most series similar to surgery for appropriately selected patients. So that means small renal masses. There is a little bit higher local recurrence rate, but outcomes, cancer-related outcomes, very comparable. Safety and recovery. So lower complication rates, less blood loss, shorter hospital stays compared with surgery. Kind of good for kidney preservation. So minimal impact on normal kidney tissue. For some patients, that's more important than others. Best candidates are going to be, maybe just not great surgical candidates, older, medically complex, high risk for surgery, or again, those just prioritizing a minimally invasive treatment. And limitations, you do need to have follow-up imaging and slightly increased risk of needing retreatment. Most series these days, about 5 to 8% patients could need retreatment, but fortunately, that's often doable with just another single needle ablation. So that's what I've got. I think a couple of references here from the talk that I included. And then if you have questions about ablation, definitely talk to your care team. This is my email here. Happy to have anybody reach out by email as well. I appreciate your time and attention. Thank you.